I will welcome everybody on this most glorious of New England fall days. It is just one of those days that you look and say, why would I want to live anywhere else? And I got up this morning, I get up very early and then watch the sunrise. And the first thing I thought of was that wonderful song, The Autumn Leaves, which I know this audience of a certain age knows very well. And it makes you want to sing it the minute that you hear it. And that's exactly what I think of when I look outside at
That's the
the
one,
autumn leaves.
when I miss you most of all.
Yes,
my
yes,
darling.
yes,
I
it's
remember.
the autumn leaves drift by my window, the autumn leaves of red and gold, right? It's just what it looks like. So anyway, so glad to see all of you for this very important topic. There's a lot of people on today. Those of us who do primary care get to hear a lot about sleep problems. It's a real issue for lots of people, not only in at older ages, but it is something that we talk about all the time and people ask about all the time. So I'm so glad that we're doing this topic, and I'm going to pass it right over now to, and so welcome to everybody. And if you haven't been on our town halls before, welcome twice. I'm going to pass this off to Susan Edgman-Levitan.
Thank you, Dr. Levine. And I feel compelled to tell everyone that I will not welcome you with the song today. And you would thank me for that if I did. So we're so happy you could join us, and it is a glorious day. And I know we're going to have a great discussion today. So before we get started, just a few things to let everyone know. Everyone except for the speakers is muted, and that eliminates any background noise like the leaf blowers. And so, you know, we just don't want anything to interrupt our speakers. To view the speaker on your full screen, you can go up to the upper right-hand corner and you can click on speaker view, or if you want to watch everybody else on the Zoom with us, you click on gallery view. So you'll see the slides in the middle and you'll see the speaker in the small box. But if you want the speaker to be in a big box, you click on speaker view. If your picture becomes jumpy or out of sync or wavy, go down to the lower left-hand corner and click on stop video, and that often will help speed up your connection. As you listen to the presenters today, please, we encourage you to please put your questions in the chat feature, which is in the middle of the bottom ribbon on the screen. We also just want to remind everyone that we really don't want you to share any personal medical information or ask a personal medical question in the chat, because everyone can see everything in the chat. And if you do have an important medical question, please reach out to your doctor directly. We'll try to answer all of the questions, and if we don't have enough time, we'll try to get information out to everyone after the call. So with that, I want to introduce our speakers today. The topic today is focusing on how do we all get a better night's sleep, and especially the use and the risks of medication. So you've heard from Dr. Levine, who is our Chief of Geriatric Medicine at Mass General. We're going to hear from Dr. Matt Russell, who is the Medical Director for the Geriatric Medicine Practice and the Director of Ambulatory Geriatric Medicine for Mass General. And then we're going to be hearing from Dr. Joanne Doyle Petrongolo, who is has her doctorate in pharmacy, and she is the pharmacy coordinator for our integrated care management program, otherwise known as our ICMP program. So with that, let's get started, and I'm going to turn this over to Dr. Russell.
Thank you very much. I just am getting this set up. Looks okay. All right. Well, I'd love to chime in about this being a glorious day. I was listening to the Brandenburg concertos as the leaves were falling as I was driving here to my mom's house, and it was just a poster perfect day. And I love this time of year as well. So I'm going to talk today about some of the medical considerations around sleep and aging. And that will begin with really talking about what is the normal sleep cycle, what are the normal changes we experience with aging. We'll talk about primary and secondary challenges to effective sleep and review the impact of poor sleep on health, and then discuss strategies for improving sleep quality. I'll be talking about some non-pharmacologic interventions, and Joanne will be talking about some medication interventions. So just so we're all on the same page about sleep, it isn't, as I'm sure many of us know, it isn't an on-off switch. There's a process from getting into bed and falling into a deep and restful slumber. And we talk about these in the 4 stages of sleep. So stage 1 is a transition from wakefulness and sleep that lasts about 5 to 10 minutes. When we go into stage 2, our body starts to notice this, and our body temperature drops, our heart rate drops. We begin to produce spindles, little EEG signs that say it's time to go to sleep. And that phase lasts about 20 minutes. Then we go into this deep, deep sleep where our muscles relax, our blood pressure and our breathing rates drop, and that's our deepest sleep. And the last stage you've probably heard is REM sleep, or rapid eye movement. And what that is your body is processing what it's gone through during the day. Your body is integrating that into your memory system. And in many ways, that's when you're having your most vivid dreams. And for many of us, we're like, well, if I'm having dreams about running and flying, why am I not flying and railing, around in bed? Your body has essentially anesthetized you from the neck down, and you're not able to act out those dreams, even though there's a lot going on in the mind. So those are the stages of sleep. But what happens to us normally as we age? So if you think about your sleep habits, maybe when you were 17 or, in high school, when you wanted to sleep until 2 p.m, versus when you're a busy adult and you're getting relatively less sleep, to now being in an older stage of life, how has it changed? What we know is that as we age, we have advanced sleep timing. And what that means is that we get tired and our body starts to signal us to go to bed earlier than when we were younger. And I think about this with my younger cousins who are getting ready to go out at 10 o'clock at night, and I'm already an hour in bed. We also have decreased sleep duration. We have an increased frequency in daytime naps, an increased number of nocturnal awakenings and time spent awake. And we have that decreased slow wave sleep. What we globally will say about this is that we have less sleep efficiency as we age. And sleep efficiency is time spent asleep over time spent in bed. The good thing to know is that most of us have had our age-related changes in sleep generally by the age of 60 years, and those of us in good health. So we're not necessarily going to experience a persistent progressive decline in sleep quality. This is a little graphical representation that shows that stage 1, actually, that light sleep increases as we age. Stage 2 stays relatively stable. The slow wave sleep decreases. Rapid eye movement sleep decreases. So we go through those 4 sleep cycles about every 90 to 110 minutes. It repeats and it repeats and it repeats. But as we get older, we have fewer REM cycles. And then wake after sleep onset means I get up in the middle of the night for whatever reason, and then how long it takes me to get back to sleep. That can increase. So it's important to distinguish insomnia from normal ages in sleep, normal age-related changes in sleep. Insomnia is both difficulty either falling asleep or staying asleep, and is accompanied by daytime impairments related to those sleep troubles. So many of us will have an expectation, I need to get 8 or 10 hours of sleep, but I'm only getting 6 and I'm up a couple of times a night. Then we as doctors will ask, okay, how is that impacting your life? Are you taking extra naps during the day? Are you finding yourself having any challenges? And if the answer to that is no, then that may not be something pathological. That may just be normative aging. Chronic insomnia is experiencing insomnia at least 3 days a week for more than 3 months or repeatedly over years. Now, it's not a small problem. 10% of people have chronic insomnia. So what happens when we don't get good sleep, good quality sleep? We're certainly irritable. Those of us who have been on call or have had children know what that feels like. We can also be a little bleary-eyed and have memory problems. It can impact our spirits. It can impact our ability to navigate safely, and we can have more falls or accidents, and we can be sleepy during the day. I think of my sleep-deprived years in training as, moments where you literally fall asleep on your feet in the middle of morning rounds. It was horrible, and I am very glad it's in the rearview mirror. Now, you'll all have heard the word circadian, when we think of what that means, it is really the way that we regulate ourselves to the current time zone. And light from sun is the original Zeitgeber, like the time giver. It tells us when and where we are. So as we think about how our circadian changes happen as we age, one thing that happens is we start to get sleepy earlier, or we can actually end up feeling sleep initiation happening much later in the day. And so in northern climes, especially when we get into the darker months of the year, people will often report sleep changes related to sunlight exposure. It's also important to understand that certain things can predispose us to have a disrupted circadian rhythm, i.e. if we switch time zones, if we are working a night shift, if we have erratic sleep-wake because of what we're doing. And then again, aging can impact our circadian rhythm. We'll talk a little bit about light therapy at the end. And I want to now just distinguish between insomnia and sleep-related disorders. There are many layers of sleep, and we could give a 6-day seminar on sleep. But it's important to distinguish between primary insomnia and then other reasons why people may have disturbed sleep. And so when I talk about sleep-related disorders, many of you have heard of a thing called obstructive sleep apnea, or have friends or family, or might even yourselves be taking the CPAP machine that you wear at night to help manage that. That is a cutting off of the airway and respirations, causing disruptions in sleep, not to the point of full wakefulness, but certainly can impair your sleep. Sometimes people, and there are two kinds, one is obstructive, which is the airway closing off, and then other kinds are more central nervous system related, and they can be related to other neurodegenerative processes. Movement disorders that can affect your sleep include restless leg syndrome or periodic leg movement syndrome. So, your spouse is saying, gosh, you're kicking your legs in the middle of the night, or you're doing this weird rhythmic thing with your legs. That can be a sign that you might be experiencing a sleep-related disorder. Again, we talked a little bit about circadian rhythm sleep disorders. So sometimes people can have earlier onset of their sleep in a time that is not convenient for them. And so we need to help them go to bed later. And then the opposite. There are things called parasomnias. So when we talk about things like night terrors, or I don't know what just happened. Sorry, here we go. There we go. Night terrors, sleep paralysis, hallucinations that are vivid that you're experiencing either when you're falling asleep or just waking up. Those are called parasomnias. Those if you're experiencing changes in your sleep and something like that is happening, then this isn't an issue of, oh, I need to take a sleeping pill. This is an issue of, I need to see a sleep specialist and actually have this explored to figure out what's going on with me. Now, what are the reasons why we have trouble sleeping that aren't related to primary insomnia or sleep-related disorders? Well, there are many, and we like to call them the 5 Ps. And the 5 Ps stand for pain, potty, potables, perseveration, and panting. And I'll explain each one of these. Many people have a high pain threshold when they're awake during the day. They can endure mild arthritic pain and discomfort. Where they can struggle is at night getting comfortable in bed because of that nagging pain. I always joke and say everyone becomes a wimp when their eyes close. The pain is real and it keeps us from sleep. We don't have that distractibility of daytime activities to keep us away from experiencing pain. So certainly understanding if I'm having pain and that's the thing that's impairing my sleep, I need to have that assessed. Potty, many of us take a diuretic or have urinary difficulties, whether it's because of urinary incontinence or prostate issues. And it means that we might have to go to the bathroom several times at night. We might be taking our diuretics at nighttime instead of in the morning, and that might be why we're having trouble with having to get up so much. So having a conversation about this with your provider is really important, because oftentimes it's what we're giving you that could be the culprit. But we'll have patients say, well, I always have drunk, 8 glasses of water and I have my last 2 an hour before bed. So we talk about maybe considering altering your fluid intake so that that nighttime interruption doesn't happen. For people experiencing lower leg swelling, and they say, I get into bed at night and by the next morning, my legs are skinny thin, but I'm up all night peeing. Well, we've eliminated gravity by having you lie down in bed, and all of that water in your tissues is now getting back into your bloodstream, and it's like drinking a big glass of water, and that's why you're having to pee so much. So we'll tell people, okay, an hour or 2 before bed, lie down on the couch with the feet elevated to see if you can help accelerate that fluid distribution into your bloodstream so you can pee a really good pee right before bed and then have an uninterrupted night's sleep. Panting refers to respiratory troubles. So sometimes people will have postnasal drip that will give them coughs and they can't fall asleep because of that annoying hacking cough. Sometimes people will experience heart failure symptoms, trouble lying flat, or they'll have a blocked nose from a cold that keeps them, that makes it very hard for them to breathe comfortably. So we'll then say, okay, let's optimize, if it's heart failure, let's optimize your diuretic regimen and make sure you're not having fluid around your lungs, and that's the reason why you're having trouble breathing. Or let's have you adjust the position of your bed so that you're able to sleep more comfortably without feeling short of breath. Potent potables. We have great stuff out there for nighttime, sleepy time teas, which are great. But sometimes teas have caffeine, coffee has caffeine, and alcohol. Those are the medications we always encourage people to avoid: caffeinated beverages and alcohol before sleep. Because caffeine is a stimulant, it will definitely impair your ability to fall asleep. Alcohol will make you drowsy initially, and it can help in that first stage of sleep. But then later on in the night, it really messes up your sleep and you don't do as well. In potent potables, and Joanne will be talking about this, I definitely want to include medications, because there are many medications that we can be giving that are actually activating. And, for some antidepressants, we're told to take them at night, but they make us wired. So then we have to have a conversation with our doctor to say, okay, maybe I should take that in the morning. The last P is called perseveration. And this is the inability to turn off your mind. So when you go to bed at night, and I had to learn this in residency, you're lying in bed and you're saying, oh, Mrs. Smith in 5A, I forgot to do this. I have to do this. And then tomorrow I have that presentation. And then did I even pay that bill last week? And, it just goes on and on and on. And to be able to turn that off is, it's not always so easy. And it warrants some exploration. And we'll talk a little bit about the nighttime rituals in a second that can help us with perseveration. But it's also important to recognize when perseveration might actually be reflecting a change in our mood, either depression or anxiety, or something like acute grief. It's really key to not just poo-poo it and say, oh, I'm just a worry wart. Maybe something has changed. And especially if you're seeing this change that you've never really had before, you should share that with your doctor. So for those of us who have not been in an emergency situation on an airplane, we generally get a warning that we're going to land the plane soon. The flight attendant comes on and says, we're preparing our initial descent into choose your destination. What do they ask us to do? They ask us, they're going to come through and they're going to take away any trash that we've accumulated. They're going to make sure our tray tables are up and locked and our seats are in the upright position. And then we can feel the plane descending and we all start looking out the window, seeing the lights, trying to recognize the landmarks. The analogy I'm trying to build here is that going to sleep is not an on-off switch, and most of us can appreciate that. We actually have to have a signal to our body that is both external and internal that says, I'm preparing for sleep phase. And I love to think back to childhood, when you'd take your bath, you'd put your jammies on, you'd brush your teeth, you'd go potty, you'd have the prayer at the bedside, maybe you'd get a story, and then lights out. And there was this whole thing that said, this is how we do it. I could fall asleep now and need an alarm clock to wake up tomorrow. I don't really need a ritual. I certainly like it, but I don't need it. But for when you're going from really busy, really activated life and then going to sleep, you have to create that ramp. And so what are some things that we can do to make sure that we're creating that healthy ritual for ourselves? So the first thing we'll talk about is sleep hygiene. You'll hear about people saying sleep hygiene, and that doesn't mean taking a bath before you go to bed because no one wants a dirty sleeper. What it means is paying attention and grooming your sleep habits so that you can get a restful night's sleep. Thinking about your sleep efficiency, if you're having trouble, concentrating your sleep at nighttime rather than during the day, decreasing daytime naps, not eating too late, certainly not less than 2 hours before bedtime, avoiding all the stimulants, alcohol, caffeine, tobacco, maintain a healthy lifestyle. If we're sedentary all the time, and then it's time to go to bed, there's really not a lot of difference there. And that can be one of the reasons why people are experiencing sleep challenges. And the answer might be, I need you to be more active during the day and get outside, get the sunlight, do activities that are both physically and intellectually stimulating for you, because your body needs to know difference between sleep and wake. Having a consistent bedtime is always what people recommend. It usually falls apart in the working folks. It usually falls apart on the weekends, but maintaining a good schedule for sleep is key to having good sleep hygiene. Thinking about what the bedroom should look like. It should be comfortable temperature, not particularly hot. It should be dark. It should be peaceful and without a lot of stimulus. See footnote. The bedroom is really good for two things, sleep and sex. So if it's not any one of those, you shouldn't be doing it in the bedroom. And this is what most sleep folks will teach. You want to make sure that you're doing that sleep ritual, that I always call it that sort of soft light activity, whether it's a word search or something soothing or reading a chapter in a book that is interesting but not, stressing. That should be done in another room. When you feel tired, you should go to the bedroom and then try to initiate sleep. Unless you are getting up at 6 a.m., there's not a reason for you to have the clock facing the bed, telling you that you haven't fallen asleep in the past, you haven't fallen asleep. If you haven't fallen asleep within 20 minutes, get up, leave the bedroom, sit in the room with a soft light, do that mindless activity or whatever it is that's just peaceful and soothing until you do start to feel drowsy. Computer, laptops, smartphones, and televisions. Many of us will fall into the habit of having those things around us as we fall asleep. And we want to make sure that that isn't part of your story. Keeping that out of the bedroom is key because those things can be stimulating from the light and the sound. I know there are a lot of apps out there. I did do some research to look into this, and I don't really have any official recommendations. What I have discovered is that smartphones in the bedroom can disrupt our sleep if we're looking at the screen. Apps can measure our time asleep and time awake, but they're not really accurate at measuring the stage of sleep. And smartphone apps claim to assist with improving quality of sleep, but that's mainly by enhancing your awareness and having you focus on a sleep diary and enforcing the daily ritual, the nightly ritual. So I'm going to stop there and pass it on to my fabulous colleague, Joanne Doyle Petrongolo at Petrongolo. Why do I keep doing this? Now I knew it before everyone, and now I can't say it.
It's
But
fine.
take it away.
Thank you. So thank you, Dr. Russell, for the overview. So I wasn't sure when you were talking before about the 5 Ps, if the pharmaceuticals was included, but it was certainly included under the potent potables. So I'm taking it as like the 5.5A sort of aspect in terms of medications for insomnia. So I'm going to touch some medications that actually can worsen sleep or make it difficult to go to sleep, and then also talk about medications that can be used for sleep as well. So really this is the meds portion of the program. Next slide, please.
I heard you, and there we go.
Okay. So this kind of goes back to what we were saying about like what else can kind of keep people awake. So some medications that are stimulants, so things like Ritalin, Adderall, Concerta, those can keep people awake. So we usually recommend that patients not take those after like 4 or 5 o'clock at night, because it can, you can be staring at, the walls still come midnight. So we recommend that you do take those earlier in the day. As Dr. Russell had mentioned, certain antidepressants like Prozac, Zoloft, those can make people feel like they can't go to sleep either. With this class of medications, it's interesting because some people it helps them go to sleep and some people it keeps them awake. So we really just kind of recommend patients, try taking it at bedtime. If you don't have any issues, that's fine. If it keeps you awake, then take it in the morning. The other class of medications that can affect people are steroids. So I think of prednisone. So people use prednisone for different things. They might use it if they have an emphysema flare or if they have arthritis flare and the dose needs to go up. And we find that sometimes when they're on those higher doses, when I say higher doses, like 60 or 40 milligrams a day, which are very high. A lot of patients have difficulty falling asleep. And once again, they're kind of staring at the walls at 2 a.m. As they taper off on the dose, they may notice that their sleep is improving. You can take them in the morning with breakfast, with some type of food, but they still can make patients feel like it's difficult to fall asleep. As the dose decreases, it certainly can improve. The other class of medications for affecting sleep would be decongestants, so like Sudafed. So that can be very stimulating for people. They may have difficulty falling asleep. So those two we recommend not taking after like 4 or 5 o'clock at night because it can keep them awake. If you can take it in the morning, you know, that's a better time to take it. If you have any type of congestion because you have a cold, you may want to consider taking the Sudafed in the morning. And then if you're still having that congestion at night, you can take something like a Mucinex, which is really just breaks up the mucus and it doesn't affect the sleep to the same extent. Other medications like inhalers and nebulizer solutions, those two can also be very stimulating. So if it's best to take those, you know, earlier in the day, you know, if you're taking that right before you go to bed, you may find that a little bit harder to go to sleep. So, you know, if you can take that, you know, before like 6 or 7 o'clock at night, if you know, you clinically can do that. Some people need to take it, you know, around the clock, but otherwise, if you can take it earlier, that's best. And then medications for Parkinson's disease or restless leg syndrome. And the meds for the restless leg syndrome, I mean, it's kind of like an oxymoron. So you want to take this because it's difficult for you to sleep, you know, you're having this condition, but some of these meds actually can make it difficult to go to sleep. So the Mirapex in general, that one actually has a very high incidence of insomnia. It's like 4 to 27%, which is pretty high. Whereas the Requip, that's a lower incidence, about 2%. So if you were using it for restless leg, you may want to go with the Mirapex in that case because it's it doesn't have the incidence is lower on that. Next slide, please. So I'm generally a glass half full sort of person, and that I like to start presentations very positively. In this case, I'm actually going to start with the meds not to use because I'm looking at this from a safety standpoint. And I really just want to emphasize these are the medications that we don't recommend in older adults, yet they are very, very well popularized as, you know, you could use these. So I just want to go through some of the over-the-counter products. You know, these are the things that we see when you go into CVS and Walgreens. Benadryl, even though it's an allergy medication, a lot of people will use it for sleep. And I have to honestly say, this is the med that when people mention, this is like my #1 med that I say do not use in any older adults. And I'm going to go through some of the side effects in just a sec. But the diphenhydramine, which is the chemical ingredient that's in the Benadryl, is in many other medications for sleep. So I have down below the Tylenol PM. Yes, it has Tylenol, but it also has the diphenhydramine. The Unisom package that's in the middle, that too also has a diphenhydramine, and that's a higher dose. That's a 50 milligram dose. So that's definitely going to make somebody feel, you know, pretty groggy in the morning. The Advil PM, that too also has a diphenhydramine component. The Unisom tablets down below, that has doxylamine, which that too is an antihistamine, which can cause the drowsiness. So, but that too is in also, you know, several other over-the-counter products. And then finally, the ZyQuil, that has the diphenhydramine in it as well. So they're in a lot of products. And so I am including, you know, the chemical name so that if you are looking at different packages, you know what to look for. So if you see any of these ingredients, then you really want to just use it very cautiously, if not at all. Next slide, please. So with these OTC products that contain the diphenhydramine and doxylamine, some of the side effects would be blurry vision, a dry mouth, so that cotton mouth when you wake up in the morning and you're feeling kind of groggy and you can't really see too good and it's very uncomfortable. Urinary retention, so it's difficult to go to the bathroom. Certainly that drowsiness, grogginess, and then just overall confusion with prolonged use. And this puts people at risk for falls, fractures, so it is concerning to be on the lookout for this. I want to really kind of emphasize the fact that the diphenhydramine component can be found in these other ingredients, especially the Tylenol PM and the Advil PM. I had a patient several years ago who had arthritis. She was homebound. She asked her neighbor to go to Costco and she got the 1,000-count bottle of Tylenol. Well, instead of getting a Tylenol, she got Tylenol PM. So the patient was taking this 4 times a day for her arthritis. And unfortunately, she developed such severe urinary retention that she was scheduled to have a permanent catheter put in place. And it was in the conversation that myself and my other colleague had with her that we identified that she had been taking truly, the Tylenol PM, not plain Tylenol, which was leading to this very serious type of situation for her. So once we identified that, we told her she had to get rid of the bottle, that she was no longer allowed to take that. Fortunately, their condition was reversible, that she didn't have to have that catheter placed, but that just shows the emphasis of how, these particular ingredients, they kind of sneak in some of these other over-the-counter products. So you just have to be very cautious of those sort of things. So my general rule is diphenhydramine and the duoxetine, not a good product for the older patients. The other class of medications that we use for sleep. So I have sedatives and tranquilizers, because that's just kind of the common words that we use for it. The chemical name would be the benzodiazepines, and we know them as some of their brand names: Ativan, Dalmane, Klonopin, Restoril, Valium, and Xanax. And I know a long time ago, people would use like Dalmane and Valium and even like the Restoril more commonly for sleep, but we've really gone away from using those medications because we know what the long-term, effects are, or long-term and short-term effects are for our older patients. Similar to the antihistamines, they have the prolonged drowsiness, confusion, memory issues, dizziness, falls, car accidents, and more importantly, they can interact with other medications. So things like your pain meds, your oxycodone, your Percocet, OxyContin, those sort of things, those can interact severely, that people have died from those combinations. So it is, when we see our patients who've been on some of these meds for a very long time, we do try to work with the patient to be able to taper off them and be off them altogether, because you may have been on them for a very long time. Maybe people started on these meds when they were like 40 or 50 years old, but as your body gets older, your body doesn't metabolize medications to the same extent. So you may have higher levels of the medicine in your body, and then that's when you might see some of these more prolonged side effects of it. So we generally don't recommend these medications for for older patients, for sleep. I'm going to talk about what we can use in just a few minutes, but these ones we really try to taper patients off. There was even a program up in Canada that was an initiative with the Canadian Medical Society and the Canadian Pharmacist Society, that when patients were calling in for their refills for their Ativan and their Valium as well, the pharmacist would counsel them, and ultimately they were able to discontinue this class of medications in about 25% of the patients. And a lot of these patients actually felt much better after that. They didn't have that level of grogginess and confusion as they did before. Next slide, please. You can go back one. There you go. Back. One more. There we go. So these are what we can kind of call the Z drugs, the Z, kind of like Z's for sleep, that we use. So their brand names would be Ambien, Lunesta, Corvique. That's a new one. So Lindsey Vonn, if you've seen any of the commercials that Lindsey Vonn is promoting these days. So this is a new medicine for sleep, a new category. Rosemron and Sonata. And similar to the benzodiazepine class, their side effects are identical. So the confusion, delirium, falls, fractures, and then certainly car accidents are certainly reasonable. And we've seen that they really didn't improve the onset of sleep. So, they weren't falling asleep any sooner, and the length of time they were sleeping really didn't make that much of a difference. A few of these medicines, like the Lunesta, the Rosemron, and the Sonata, those actually, they also have a side effect that you can cause like swelling of the lips. And that would be after like the first couple of doses of taking those medicines. It's not as super common, but people have reported it. So, that particular group of meds, we don't really encourage for our patients because of, the side effects, as I've just mentioned. Next slide, please. So here's the good news. What can we use? So our first line of therapy when patients are having difficulty sleeping and they've already implemented the non-pharmacologic interventions that Dr. Russell had mentioned. So melatonin is really our first line. So melatonin occurs naturally in your body, but as you get older, the body decreases, the production of melatonin decreases in your body. So you can supplement it by using, they have capsules, they have tablets, they have films, they have gummies, they have all sorts of things. And so we really start with melatonin first. For some patients, even if they try the melatonin, it may help them fall asleep a little bit sooner, but then they may still be finding that they're waking up at like 4 or 5 o'clock in the morning. There are extended release formulations that will go longer. So instead of waking up at 4, maybe now you can wake up at 7. So it's just a matter of, finding the right formulation for you. You can start out at a lower dose of like 1 or 2 milligrams, and then you can certainly go up to like 5 or 10 milligrams. And if you need to try one of the long-acting formulations, you can do that as well. But this is really, this is kind of like our first line that we recommend for our patients. Next slide, please. And so once we've tried melatonin, and if that didn't really seem to work for you, the next one that we look at is trazodone. So both trazodone and Remeron, they're actually in a unique antidepressant class, but they can be used for sleep. And this is what we use the trazodone mostly for sleep for our patients. So you can start at, some patients might start at a dose of 25 milligrams, but we actually find the 50 milligrams to be a little bit more effective. And the side effects are not going to be the same as what you would see with the other classes that I've mentioned. You don't wake up with that same level of grogginess and confusion as you would with the other meds. Remeron, so Remeron, as I mentioned, it could, yes, we're using it for sleep, but it's also an antidepressant, and they also use it for weight gain. So if patients are having, as they're getting older and they're having this difficulty with sleep, and maybe they're kind of down in the dumps and they're not eating as much, this actually helps stimulate the appetite as well. So we may use this medicine to kind of catch 3 birds with 1 stone, because it has that effect on those. And this too, the side effects of this are not going to be the same as which you would see with the other the benzodiazepines, the Ativans, and things like that. Next slide, please. And then finally, there are a lot, if you go to CVS and Walgreens these days, there's like a whole section of, herbal supplements, nutraceuticals, and just other supplements in general. And so I just wanted to highlight a few that tend to be a little bit more common these days. So we have valerian root, ashwagandha has been more popular lately. I've actually been seeing like a whole bunch of commercials on TV for that. Passion flower is another one. So those are some herbal supplements, and they work similar. They work on the same receptors that the benzodiazepines, that the benzodiazepines would use affect. And so those two can, obviously cause some drowsiness to help you go to sleep. But you want to make sure that it's not going to interact with any of the other medicines that you use. So we encourage people to really talk to their pharmacists and their physicians. And I'm going to obviously promote pharmacy because I am a pharmacist, but pharmacists also have, we have a database, a very easily accessible database that we can look up these drug interactions. So it is, we usually encourage that because they do have these side effects, not only just with the like benzodiazepines and things like that, but it can also affect the liver. So we just want to make sure that if there's other medicines you're taking that might affect the liver, that there's not going to be any interactions with those. And then at the bottom of the slide, I've also included this ZQuil, which has melatonin, which we already mentioned, and chamomile and lavender, which can also be very relaxing, helping with anxiety, help, calm people down. Dr. Russell had talked about like certain teas. So there's certain like chamomile teas that are certainly reasonable to take that can be relaxing to help people go to sleep as well. And then finally, I just want to touch upon magnesium. So although there's not a ton of studies, there have been a few studies that have shown that magnesium can help with some sleep. So it actually works to and can stimulate melatonin production, and it also stimulates the same receptors that the valerian root and the Ativan medications, it's the same receptors that will be stimulated to kind of help people like calm down and go to sleep. So I'm just showing just like a regular generic bottle of magnesium, but it can come in other formulations too. There's another product called Calm, which comes in a powder. So you mix that first with hot water, and then once that's diluted, then you can mix it with cold water and just kind of like sip on it too. And so that's another product that some people find to help with not just insomnia, but also anxiety as well. So that's just something else to kind of keep in mind. Next slide, please. So really to just kind of wrap things up a little bit, you know, there's a lot of factors that can affect people's sleep. You know, as Dr. Russell had mentioned, you know, getting up a lot to go to the bathroom, having, you know, coffee and tea or coffee and alcohol before you go to bed, you know, those can certainly affect people. If, you know, you're sitting watching Netflix and it's a scary show, you know, that might not be the best thing for you either. But if you're able to incorporate some of these non-drug therapies, you know, some of these other lifestyle changes, and, you know, there are some other apps like Calm and Headspace that can also help kind of like calm people's brains down a little bit too. And those can certainly help sleep. But if those other non-pharmacological interventions still aren't working, yes, there's medications and other supplements that you can use. But it's really, we really want you to have a conversation with your healthcare provider about this, because we want to see what's going to be the best option for you. So everybody has a different story. Everybody has different conditions that are going on, and you're all on different medications. And so we want to make sure it's going to be the right fit for your lifestyle, for your medications, and make sure that there's not going to be any drug interactions that are available. But really, we want, you know, make sure that everybody, you know, it's harder as we get older, you know, the sleep. But there's definitely options out there. It's just a matter of being able to talk to your doctor, see which one's going to be the best for you. Thank you.
Thank you. This has been a very rich discussion, and I think I'm going to need to listen to the recording again. So we do have some questions. The first one is, there's a lot of discussion about sleep and memory impairment. If you sleep less than 7 or 8 hours, but don't have daytime impairment, is there still a negative effect on your memory?
So we make these recommendations really painting with a very broad brush. And I think it's important to know what kind of a sleeper you've always been. So there are some of us who need a full 10 to 12 hours of sleep to feel restored. There are those who just need about 5 to 6 and they feel fine. I think in general, the assumption that older adults need less sleep than the general population is false. Once you reach a certain age in adulthood, we all need, our usual amount of sleep. It's not like suddenly, if I've always needed 10 hours of sleep, now that I'm older, I only need 4. And sleep deprivation, we know for both intrinsic disorders and also medical disorders, and just sleep deprivation in general for any number of reasons, it is definitely associated with impaired cognition, depression. So it behooves us all to strive towards getting good restorative sleep.
So the next question is, and Dr. Russell, I'm going to direct this to you, is why can we not get Ambien from our doctor? That's a broad question. Oh,
yeah. And I think that, one thing we really wanted to drive home with this discussion is, one, empowering our patients to understand, do they actually have insomnia that's impairing function, or do we have, is this just normal aging? The second thing is, what has been evidence-based shown to be effective for insomnia, the one thing that has absolutely had long-term benefit is cognitive behavioral therapy, which can be done through some smartphone apps. Again, I can't speak to which ones because I didn't really find great evidence in the literature for one over the other that wasn't sponsored by the app itself. That's the main thrust, all the stuff around sleep hygiene, all the other things, the considerations. When we get to a point where someone needs a medication, we always want to balance what is that medicine, what is the hope for the medicine to do, and what are the toxicities. And with medication interactions, medication illness interactions, and medication syndrome interactions, we as geriatricians are very cautious as gatekeepers to make sure that if I give you this thing, it's not going to have untoward outcomes. Ambien has, like Joanne said, and Joanne, feel free to, to chime in here. These are medicines that I would say they don't do normal sleep in the way that we just discussed in the normal phases of sleep. In many ways, it's just you close your eyes and all of a sudden you're awake, but did you actually get restorative sleep or not? The data they've shown is when people are receiving this by itself, it's not so great. But if you receive this with cognitive behavioral therapy, the impact is longer lasting. The other medication, a lot of times people take melatonin as if it were a sleeping pill. And it's important to understand the mechanism of how melatonin works. Melatonin is the initial announcement that says prepare for sleep. So it's not when the plane is landing, it's when the plane is doing its initial descent. So if you want to take melatonin, you should be taking it about an hour before the planned moment of sleep. Many times people will say, it doesn't work for me, it doesn't work for me. I'll eventually fall asleep, but I'm just lying in bed for an hour. And then we say, that's why we want you to make that change.
So
we've had some patients who have actually taken like even 2 or 3 hours ahead of time. And when I mentioned the dose, so some people might say it doesn't work for me, but they're only taking 1 milligram. And they can certainly, there's a lot more room to grow in terms of the dose on that too. So,
Okay.
there are certainly changes. And then in terms of the Ambien with the side effects, I just want to reiterate, I was talking about drowsiness and falls and those sort of things, but there's other side effects, hallucinations, sleepwalking, sleep eating. I had one gentleman who was actually waking up in the middle of the night hitting his wife, and he didn't even know he was doing it. Actually, this is a good case to just show that he was having difficulty sleeping, and they put him on the Ambien, and he was having the side effect, but really he was having overall anxiety. So we stopped the Ambien, we put him on a regular antidepressant, and that changed his mood, and that improved his overall sleep, and he didn't need to have anything else for sleep. So, it's really doing that deep dive in terms of what the drivers are that are causing some of those sleep issues. So it's not just, we don't want to just throw pills at it. We really have to do that investigative work to figure out all the different nuances that are causing that.
Great, thank you. So there's another question there are a couple of questions about, do these eventually stop working? The melatonin, gabapentin, other things that you've mentioned, if you use them regularly, do they eventually lose their impact?
It's one of those things too, in terms of, do you feel like you need to use it every single night? And so, that's where, once again, doing that deeper dive to figure out, is this a chronic issue? What else do we need to do? Do you really need to have these every single night? And this is why we have the step line therapy. We do the melatonin, we do the trazodone, we do the mirtazapine. And then, if you really need to go the Ambien, then we'll start with a lower dose of that. If it's really even appropriate. So it's really just going through the stepwise process to figure out if those are the right things. So throwing a whole bunch of things all at once is not necessarily the right answer. It's really just, looking at it chronologically, what you have tried.
It's a really great point. And I think that, when we have, a medicine that's designed for something that is not working, that tells us maybe we have the wrong problem that we think it is. And so it begs us then as clinicians to explore a little further. Is your reason for sleeping subclinical heart failure? Is your reason for sleep impairment you are actually having decompensated depression? Many people will realize in hindsight that they had depression because we might have an image of what depression looks like as, a maudlin person, looking out the window on a rainy day, listening to the Carpenters and just being sad and sad. That isn't necessarily what the phenotype of depression looks like as we age. It can be more irritability, sleep disturbances, changes in our appetite. And we may not even have those overt, sadness moments. So that's why having that discussion, doc, I've tried this and it hasn't worked. Well, maybe we need to look at this anew.
Today we have a sleep and a musical theme. So I think we have time for one last question, and that is someone has submitted a question about what are other uses of trazodone?
It's generally for sleep, even though it does have the indication for depression. But we don't generally use it a whole lot for depression. And then with some of our patients with dementia, we'll also use it for the condition in what we call sundowning. And so it helps with some of that irritability component that you may see. And you can see it at different times during the day. So we may actually use it, even though we use it for sleep at bedtime, somebody may also use it at 11 o'clock in the morning if they tend to be more irritable in the afternoon as well. But that's a very kind of like unique sort of group.
Okay.
I did just want, before we end,
ahead.
I did just want to just say one thing about meditation and light therapy. Mindfulness and meditation is certainly helpful for managing anxiety and mood, and that can have an impact on sleep. And it can also be a delightful part of your getting ready for bed ritual. So it's never going to be something we don't recommend. Light therapy for people who are having early or change in their circadian onset of sleep, i.e. they're getting sleepy too early or getting sleepy too late, that can have an impact. But I just wanted to put it out there because a lot of people will talk about sleep and seasonal affective disorder, and that has been shown to have some efficacy.
Yeah,
And
and
I'll be quiet.
oh, that's okay. I would just add that many of the meditation apps like Calm, Insight Timer, 10% Happier, all have sections on the app that have sleep meditations, and they're, I would say in general, they're all quite good. So I would take a look at that. And we did also check with our Benson Henry Institute to see if they do any cognitive behavioral therapy, the CBT training, and they don't right now, but I know that there are resources for that are online. So I'm going to see if Dr. Levine has any closing comments or songs. You're on mute.
I guess the one thing that I would say is there are some times when there's a tragedy in the family or a death or something that's really going to keep you awake at night during a time of grief. And that's not what we're talking about today. There may be a time when you just can't sleep because a really hard thing has happened in your life. And that's worth talking to your doctor about. That's not a chronic sleep disorder. And I think it's important to think about that. I think it's really important to realize how common this is and how many requests we get about this because of all of the things that Dr. Russell talked about, and also all of the medications that can affect our sleep that we're not taking for, that are not taking for reasons like sleep, like inhalers, for instance. And so it's always great to talk to your doc or nurse practitioner about these things. It's a very important thing. And I really want to thank Dr. Russell and Joanne Petrongolo for helping us with this. And this is different than psychiatric history. That's an entirely different, this is a symptom often with people who have anxiety and depression. And I do think there's cognitive behavioral therapy available in Boston for sleep at different sites. There's always long lines and waiting for these things, but they're worth a try.
Yeah, thank you. So thanks to everyone. I hope you have a great rest of the day, and encourage everyone to go outside and get a little exercise. That'll help you sleep better tonight.
Get
and
that sunlight.
sunshine. Get that sunshine. So thank you so much. We'll see you next month. Take care.